Hello to everybody. It's a pleasure for me to be here with you. And may I? Sorry, we have some technical problem. Okay, now it's working. It's a pleasure for me to be here with you and just to share the, okay. To have the possibility to be with you and discuss about problems in hypertension. My name is Stefano Taddei, and I am professor of internal medicine at the University of Pisa. And this is my conflict of interest. And this activity, this live webinar, is part of a more complex and articulated educational activity of Media Academy, but we'll come back on this specific activity at the end of the webinar. Just some practical concept. The specific title of the webinar is Hypertension, Novel Treatments and New Positioning of Beta Blockers in Cardiovascular Management. And the learning objectives are to appreciate the novel and up-and-coming treatments and management strategies for hypertension, have knowledge of the updates and latest ESHA 2023 guidelines, be familiar with the new guidelines on positioning of beta blockers in cardiovascular disease management. And I'm really honored to introduce the faculty of this symposium. We are among the best experts in hypertension and cardiovascular disease that we have in Europe and I would say in the world. Professor Reinhold Kreutz from the Charité University of Berlin, and Professor Kostas Tsoufis, Professor Cardiology at the National and Kapodistrian University of Athens. You know, for sure, you know both, and we are among the maximum experts in this specific field. And we have partnership from different national societies, including the Belgian Hypertension Committee, Chinese Hypertension League, Iraqi Hypertension Society, Indian Society of Hypertension, Israeli Society of Hypertension, Hungarian Society of Hypertension, and Ukrainian Hypertensive Society, and we have the direct endorsement of the Italian Society of Hypertension. And this is our international committee. And what is the most important is the agenda of the live webinar. You will see we have two different talks. The first from Professor Kreutz, novel treatment in hypertension, the novelty we have in this specific field, and the second talk from Professor Kostas Tsoufis, new positioning of beta blockers in cardiovascular disease management. After the two presentations, we have time for a final discussion. So you will see you have the possibility to interact with the faculty, and just this is probably the most important part of the webinar. The accreditation, this program has been accredited by the European Accreditation Council for Continuing Medical Education with the one European CME credit, and the program has been certified by the CPD Certification Service as conforming to continuing professional development principles. And we have simultaneous translation. You can decide if you want to listen the webinar in English, Russian, or Chinese. You have to choose the language that you prefer. And the important part, the question and answer, you see you have a Q&A section, then you can use just to write your question, and the faculty we will respond directly, we will respond you. And finally, the certificates will come back later, but you have to complete the post-webinar survey at the link provided in the chat. At the end of the seminar, the organization will provide the link. You can connect, you can complete the post-webinar survey, and then you can download both certifications. And last but not least, we have to thank Merck Company, who will, by an independent educational grant, allow us to organize this symposium. So I let the microphone to Professor Croix that will speak us about novel treatment in hypertension. Thank you, Reinhold, to be with us.
Yes, Stefano, Professor Tadei, it's a great pleasure and honor for me to participate at this symposium and this educational activity together with Professor Zufis. So these are my disclosures. This is a very short introduction slide to inform you about aspects that are related to my topic, but I'm not talking about established drugs that have become available now in a new context, for instance, chlorthalidone in CKD, or established drugs that are combined in a very low dose, the quad pill. And also I'm not talking about SGLT2 inhibitors or GLP-1 receptor antagonist or device-based therapies that also have a blood pressure, clearly blood pressure lowering potential. The drugs and of course renal denervation has been now also recommended for hypertension treatment. What I'm doing is really to talk about novel drug medication developments. We can classify them drugs that are being developed within the renin-angiotensin-aldosterone system, and you see in this complex slide, you know, all the drugs available and the major mechanisms controlling blood pressure and the available drugs and their mode of action. So we have the drugs acting in the renin-angiotensin-aldosterone system, and there are new developments, exciting developments, and also outside the renin-angiotensin-aldosterone system. I will start with the drugs that are being developed outside the renin-angiotensin-aldosterone system. The first important one, probably the most important one, outside the renin-angiotensin-aldosterone system are the endothelin receptor antagonist. You know, endothelin-1 is the major agonist, is the most potent endogenous vasoconstrictor, more potent than angiotensin-2 actually, and it works via two receptors, the ETA and the ETB receptor. And this is a slide summarizing the effects, but I just want to highlight that it was believed that the ETA receptor is the most important receptor because it induces vasoconstriction, so we should block the ETA receptor. While the ETB receptor is related to natriuresis, it was considered not to be favorable to block this receptor. But that has been changed now in the development. Surprisingly, the selective ETA receptor did not work in humans. Works very well. We did also animal studies very well, but in humans it didn't work. So basically the development was in the direction that we have to block both receptors, the ETA and the ETB receptor. And that has been done, and most successfully with aprocitentan. So this is a dual endothelin ETA and ETB receptor antagonist. There's even an abbreviation for this, DERA, the dual ETA and ETB receptor antagonist. Of course, you know, there's the pivotal trials are phase 3 trials that lead to approval if they are positive, and that happened, was published in the Lancet and presented at American Heart by Markus Schleich from Australia. In resistant hypertension, the term was positioned for the trial in patients, 730 patients with resistant hypertension on top of 3 triple therapy. The primary endpoint, surprisingly, was automatic office blood pressure, very short term, 4 weeks only. You can see here, in response to placebo, there was some blood pressure lowering from about 140, 54, or 53 baseline on triple therapy. But the two doses of aprocitentan lowered the blood pressure, 12.5 and 25, they lowered the blood pressure. And after 4 weeks, all patients were maintained at the lower blood pressure by using only the aprocitentan 25 milligram, and then they were re-randomized to placebo. The blood pressure went up again, or maintained the aprocitentan dosage. The same was shown for diastolic blood pressure. If you focus here, the primary endpoint, aldosterone, placebo-corrected blood pressure lowering was about 3.8, 3.7, no dose effect. So let's say about 4 millimeter mercury blood pressure lowering, systolic blood pressure lowering in patients with resistant hypertension on top of triple therapy. There was, however, still a signal, although we have dual ETA-ETB receptor blockade, for some edema or fluid retention. You see in the placebo group, 2.1% developed edema, while 9% or 18% dose-dependent effect developed edema in the aprocitentan group. So there's still a safety signal or an unfavorable side effect, some edema formation. However, it's very important, if you read the heading of my slide, the first novel compound after aliskiren, the renin inhibitor that was approved in 2007 in hypertension for the treatment of hypertension, is now approved, aprocitentan, both in the United States by the FDA, March 24 or June 24 in the EMA. So it's approved, but not yet available on the market in the doses of 12.5 milligrams in Europe, and also the potential to uptitrate to 25 milligrams. The second, and actually already the final promising development in outside the renin-angiotensin aldosterone system are drugs that are agonists of the natriuretic peptide. You know the cardiologist, and you know that sacubitril valsartan is also using this mechanism activating indirectly the natriuretic peptides, but there is also a potential to really have modified molecules, genetically modified molecules that stimulate the an ANP receptor, which is the GCA membrane-bound receptor, and thereby you can induce natriuresis, vasodilation, also suppress aldosterone, thereby lower blood pressure. And there's development in in human studies already presented. So this is a phase 1 trial in hypertension for a modified ANP agonist. And the results are shown in this slide. A few individuals were tested, and they had this peptide injected, because the peptide obviously needs to be injected subcutaneously, cannot be taken by an oral route. But you see here in the different patients, you see the blood pressure, the mean group of the means of the blood pressure lowering effect, systolic on the top, or the diastolic, and also a consecutive heart rate increase if you use this drug as a monotherapy, and a dose-dependent blood pressure lowering potential that is shown here in the slide. So there's actually a phase 2 study in patients with difficult to control or resistant hypertension ongoing. It's still recruiting. I say that it's still recruiting, so it's a promising drug. However, we have to acknowledge there was another compound actually that was bought by Novartis, and they had a similar drug also tested in patients with hypertension, but also in heart failure, and that was stopped because of futility, because that was negatively seen in the interim analysis of a phase 2 trial. So we have to see whether that indeed holds true, that this is a promising, successful development. So that brings me already to the end, and that's also a point for discussion, that not so many drugs are actually being developed outside the renin-angiotensin aldosterone system. Now focus on the renin-angiotensin aldosterone system. There we have two major developments related to aldosterone signaling. First of all, we have the very well-known steroidal mineralocorticoid receptor antagonists like spironolactone, eplerenone, and then we have the non-steroidal. They have a different structure. They are bulky. They are not flat like the steroidal antagonists, and therefore they have a major advantage. So finerenone and esaxerenone are approved. Finerenone for diabetic nephropathy, esaxerenone for hypertension, but only in Japan. And then we have the aldosterone synthase inhibitors. They inhibit this biosynthesis by blocking the crucial enzyme 11B2 and thereby aldosterone synthesis. So what the difference could be or will be between the two different mode of actions. If you have a mineralocorticoid receptor antagonist, you block the receptor and you block only the classical effects that are mediated by the mineralocorticoid receptor. But aldosterone can also exhibit effects independently from the mineralocorticoid receptor. And these are the so-called non-genomic fast mechanisms that are mediated, for instance, via the G protein coupled estrogen receptors and other signals. So the advantage of the aldosterone synthase inhibitors would be that you block all effects of the aldosterone, while with the mineralocorticoid receptors, you block only those that are mediated via the classical genomic pathway. And there are different drugs in development. So within the non-steroidal MRIs, there was a drug development, and the advantage obviously could be that they have a lower risk of hyperkalemia, and they have definitely, as compared to the steroidal drugs, no sex hormone-related side effects. So this is a major advantage. So the drug that was being developed was oxydurone, and it was actually developed by a small biotech company, and then it was bought by Novo Nordisk, and they conducted in CKD patients with uncontrolled hypertension, the Clarion CKD trial, and more than 600 patients were enrolled. And there was also an interims analysis, and that was pre-specified. And again, for fertility, it was stopped. So unfortunately, we had a promising drug in hypertension, probably leading to resistant hypertension in CKD patients, but it was stopped, the development. So that was a disappointing results for the non-steroidal MRI in the hypertension field. Now, for the aldosterone synthase inhibitors, we have promising developments. At least 4 compounds are being processed in the clinical development. And let me show this slide, just presented a couple of weeks ago in the European Society of Hypertension meeting in Milan, a phase 3 trial with lorundrostat in patients, 1,000 patients that were not controlled, being treated with between 2 and 5, up to 5 antihypertensive drugs. You see here the inclusion criteria for the automatic office systolic blood pressure or diastolic blood pressure, and they were treated with a dose of 50 milligram once daily, and there was also potential to uptitrate the patients from 50 to 100 milligram based on the design 1:2 to 1 ratio in 3 different groups. The primary endpoint actually was in the 50 milligram group, primarily at 6 weeks. So also an early endpoint for this trial in terms of the blood pressure lowering effect. You see the patients were about 62 years old. There were women included. There were also Black African Americans included. And 60% of the patients had at least 3 antihypertensive drugs, so they would qualify for treatment-resistant hypertension. They were also obese. At least 63% had obesity, so quite a high-risk population. You see the placebo effect in the office blood pressure and lorundrostat, and the placebo-corrected effect is 9 millimeter mercury. Quite a substantial placebo-corrected blood pressure lowering potential for systolic blood pressure, as the primary endpoint is in this high-risk patient group. And after 12 weeks, there was the primary analysis again in the 50 milligram group, but also in those that were still uptitrated. And that is in agreement with previous phase 2 studies. So the higher dose doesn't bring actually a benefit. So the dose that will be potentially develop further and will go probably for approval will be 50 milligrams of lorundrostat in hypertension treatment. There's another very promising one I just would like to mention that has been already presented earlier in phase 2 trial, baxdrostat in treatment-resistant hypertension, published in the New England Journal of Medicine. And you see here also the blood pressure lowering drug as compared to placebo, and also placebo-corrected blood pressure lowering potency in a similar range. About here it was 11 millimeter mercury, placebo-corrected. So also again a quite substantial blood pressure lowering effect in resistant hypertension, similarly to the lorundrostat. There's another one, vicadrostat, that has been first tested and presented now in a phase 2 trial context in chronic kidney disease, for instance, The Lancet published. And there's also a subsequent analysis with regard to the blood pressure lowering potential. And I show this slide because it's important for the future development. These drugs are developed for hypertension, but also for CKD and heart failure in combination with also SGLT2 inhibitors, because they are now evidence-based treatments for these conditions. And that has been analyzed in this vicadrostat study, where the patients were treated with maximal tolerated RAS inhibitors, ACE inhibitors, or angiotensin receptor blockers, plus empagliflozin. And then they were analyzed with regard to their placebo-adjusted blood pressure difference. And you can see that the blood pressure lowering difference here in the high dose, 10 or 20 milligrams, was in the range of some variability. It's a phase 2 trial, not so many patients in the groups, but up to, let's say, 4 millimeter, 5 millimeter mercury blood pressure lowering effect, independently from the treatment of background treatment of empagliflozin. So we have an ongoing development of these aldosterone synthase inhibitors in patients with hypertension and also chronic kidney disease and heart failure, and the studies are ongoing. Very exciting studies are ongoing. Finally, I would like to talk about the very interesting novel long-acting blood pressure lowering therapies. Here's a nice summary figure. So there are different aspects, including also device-based therapies, but the most promising one and more in advanced development are those that target expression of the angiotensinogen in the liver. And there are two different modes of actions that can be used. These are all injectable drugs, either antisense oligonucleotides or RNA interference or inhibiting technologies. So, and these are developed, and I would like to focus and present only the data on those that use RNA interference therapy. And because they are really long-lasting blood pressure effects with monthly blood pressure lowering potency, as you can see in this trial that has been published in the New England Journal, already with one injection of zilebesiran, as compared to placebo, you see the blood pressure lowering effect dose-dependent over week 8 and up to week 24. So that means 6 months blood pressure lowering potential up to systolic 22.5 millimeter mercury, which was quite substantial. Also, of course, this adverse events were analyzed, and there was some also positive results, no major excess of adverse events, so quite good tolerability. There are ongoing studies, phase 2 studies and further studies. I show you just this one, which is very important. The question whether they can be used in combination therapy, this drug approach with classical medications. And you see that here in comparison, or in combination, I'm sorry, in combination with indapamide, amlodipine, or olmesartan, you can lower the blood pressure with this compound, but maybe as expected with the diuretic, if you stimulate with the diuretic the renin-angiotensin system, and then you block the renin-angiotensin system by blocking the expression of angiotensinogen in the liver, you can have you induce the more pronounced blood pressure lowering effect. So in other words, the blood pressure lowering effect in combination therapy with the diuretic was more pronounced as compared with a calcium channel blocker or an angiotensin receptor blocker after 3 months. So the question is why we have, the complex blood pressure regulatory system, only a few drugs available being developed in outside the renin-angiotensin system. We have seen the successful already approved endothelin receptor antagonist and the atrial natriuretic peptide antagonist. And we hope for properly that with genomic research and also artificial intelligence, maybe that is an outlook in the future, we may develop or identify new pathways that will also identify new targets for blood pressure lowering therapy and drug development outside the renin-angiotensin system. That's something that's promising and we hope for, because we still have problems in many patients that we cannot control with the existing drugs. That brings me to the end and the summary and conclusion slide of my presentation. So in summary, several novel antihypertensive drugs are under development. They are predominantly developed for uncontrolled or resistant hypertension. Novel drugs outside the renin-angiotensin system, as mentioned, only a few drugs, somewhat disappointingly. The dual receptor endothelin receptor antagonist, DERA, aprocitentan, has been already approved in 2024, and the mutant atrial natriuretic peptide antagonists are still under development, even though there was one disappointing result with the Novartis compound already seen recently last year. Novel drugs inside the renin-angiotensin system, very exciting developments. Several are very promising in phase 2 and 3 development. The aldosterone synthase inhibitors also developed for chronic kidney disease and heart failure. And the RNA-based therapy targeting angiotensinogen in the liver exhibit a very long-term action, and thereby possibly overcoming barriers of non-adherence and under-treatment if we, inject them just, every 6 months or so. That is a potential major advantage of these drugs, and I'm looking forward to the final discussion and your comments you may have. And thank you already for your attention at this point. Thank you very much.
Thank you, Reinhold. Now, wonderful presentation and a lot of information, new promising drugs. Now we move to the second presentation from Professor Kostas Tsoufis. He will discuss about the new positioning of beta blockers in cardiovascular disease management. Kostas, the microphone is yours.
Thank you, Professor Taddei. Thank you, Stefano. It's a great pleasure for me and honor to participate in this. Do you hear me, first of all? Okay. It's to participate in this nice webinar along with Professor Kroins, and his talk provided me an excellent background to continue with my presentations. Okay, just a moment. Here my conflict of interest and the objectives has already been presented by you, Stefano, and I will go directly to my talk. I have decided to start with some introductory statements regarding the role of beta blocker. First of all, we all agree that beta blockers represent the most heterogeneous drug class among the 4 classes of antihypertensive medications. Accordingly, the beta blockers have been classified into 3 generations. The first generation with the non-selective beta antagonism, including here, for example, pindolol, sotalol, nadolol. And these first generation beta blockers have distinct side effects, bronchoconstrictions, and the risk for diabetes. The second generation is the generation that we used in the everyday clinical practice with a clear beta-1 antagonism. Here we have atenolol, bisoprolol, esmolol, and metoprolol. and we are all very well familiar with the favorable safety profile of this second generation beta blockers. And a third generation includes vasodilator beta blockers, non-selective as the carvedilol, labetalol, and beta-N selective, including nebivolol, with a specific additional, let's say, vasodilator effects. Apart from this classification into the three generations, also beta blockers could be classified in those with intrinsic sympathomimetic activity, like pindolol, and those without this activity, propranolol, sotalol. And also, there is another classification according to the lipophilicity, like propranolol, and bisoprolol, and this is something that we have to take into considerations regarding the effect in the brain. So this is, let's say, characteristics that differentiate one beta blocker from the other beta blocker. Coming to the mechanism of action, we know that the main mechanism related to the suppression of cardiac beta-1 adrenergic activity. And by this way, the beta blockers could reduce the stroke volume and also the heart rate. The reduced stroke volume results in, along with the decreased heart rate, to the decrease in cardiac output, leading to the decrease in systolic and diastolic blood pressure. And by this way, we have, let's say, an improvement in myocardiac oxygen demand and supply. Don't forget the important interaction between beta blocker and the renin-angiotensin system, and we know that beta blockers could suppress the renin release. But let me discuss a little bit more the important effect of beta blocker on heart rate. We know that coronary perfusion is related to the diastolic period, and decreased heart rate is synonymous to increased diastolic period. That means that we have a favorable effect on coronary perfusion. And for this reason, beta blockers are very, very important drugs for treatment patients with coronary artery disease. Additionally, we know that increased heart rate is associated with adverse cardiovascular outcomes in different clinical settings. Here, as we see from the old but very important CIST-EURO study, in patients with hypertension, increased clinical heart rate is associated with increased mortality rate, and the same is true in both genders, male and female. On the other hand, as we see in these slides, a heart rate has been recognized as an important risk marker of cardiovascular disease. This is true for patients with heart failure, for other comorbidities, for left ventricular remodeling, for ischemia, as explained previously, as well as in accelerated atherosclerosis. So it's important when we have to manage a patient in order to protect the cardiovascular system to take into account the level of heart rate. Having all this favorable pathophysiological background, why nowadays we have this, let's say, debate about the clinical use of beta blockers regarding the recommendation by different guidelines? We know that beta blockers have been regarded as one of the first-line treatments of hypertension by all guidelines issued up to the beginning of 2000. However, some recent guidelines suggest that beta blockers should not be considered as first-line treatment because they are not so protective for cardiovascular outcome, or their protective effects are less evident compared to other drug classes. Let's discuss a little bit more on this issue. we see here in this study published by Law, a large meta-analysis included 354 trials with a reasonable number of patients, that the systolic blood pressure decrease is similar when we compare the blood pressure, systolic blood pressure reduction achieved by beta blockers compared to CCBs or to ACE inhibitors or to thiazide diuretic. However, if we see, let's say, in this meta-analysis performed by Kostas Stomopoulos a couple of years ago, when we compare beta blockers, first and second generation, compared to the other placebo-controlled outcomes, randomized controlled trials, we see that the beta blockers are less protective for composite cardiovascular events, particularly for stroke, but compared to other antihypertensive medications. Of course, it is true that when we, let's say, limited this analysis only in patients with hypertension, in the hypertension trials, we see that the composite stroke, cardiovascular disease, and heart failure has a favorable outcome when we use beta blockers. That means that at least beta blockers could have this clear benefit in patients with hypertension. If we go to the Cochrane analysis, compare beta blockers versus placebo, beta blockers versus diuretic, or beta blockers versus CCBs and angiotensin system inhibitors, we see that treatment of hypertension, as we know, leads to reduction in cardiovascular events with a degree of reduction depending on the type of medication used to initiate treatment. Starting therapy with CCBs or RAS blocker produces higher declines in cardiovascular events than with beta blockers. There is a lot of criticism in this meta-analysis, and Kostas Stomopoulos again performed a new meta-analysis trying to identify if there is any difference in cardiovascular protection among the different antihypertensive class medication. Based on this analysis, we can conclude that the available data does not allow us to formulate a fixed paradigm for that a specific drug classes, antihypertension drug classes has a favorable effect in one in the other outcome compared to the other. However, we can say that based on the profile of each patients, at least there are some who can select a specific drug for a specific cardiovascular protection. For example, we see here that beta blockers are less protective for stroke compared to other drugs, but are equally protective compared to cardiovascular disease, heart failure, or the composite endpoint included all-cause mortality. And this is very important, giving us the freedom to use beta blocker, particularly when hypertension is associated with other comorbidities. Let's discuss why beta blockers may be less stroke protective compared with other antihypertensive class for the same blood pressure reduction, because we know that the main target when we have to manage hypertensive patients is to reduce the high blood pressure to achieve the guidelines recommended blood pressure target. There are some potential explanations. For example, it has been hypothesized that in some trials, systolic blood pressure reduction was higher in the non-beta blocker arm, like the ASCOT trial. This hypothesis was rejected by this meta-analysis by Thomopoulos of all beta blocker trials in which blood pressure reduction was on average similar between treatment arms. Another hypothesis suggested that atenolol, that was most frequently used in randomized controlled trials, might be associated with a smaller reduction in central blood pressure. We know the example of ASCOT CAFE study. this hypothesis was also rejected because we did not found no outcome difference between atenolol and other beta blockers in our meta-analysis. And another possibility is that beta blockers possess less blood pressure unrelated or direct cerebrovascular protective properties than other antihypertensive agents. Maybe there are different brain concentrations among these drugs, but on the other hand, experimental evidence of neuroprotection of amlodipine and carvedilol have been proven, but this is not the case with atenolol. And we know very well the long discussion about the adverse effect of beta blocker on new onset of diabetes mellitus. There are some data supporting that at least the non-selective beta blocker increase the risk of new onset diabetes mellitus. And particularly atenolol, we know that has been used in many fundamental hypertension trials. It has some limitations, short half-life time, 6 to 9 hours. Its effects is related to the high dose, and also it's related to the road of eliminations, may provide some explanations for this not so protective effect of beta blockers. On the other hand, we know that there are some other effects that less or more contribute to the reduced cardiovascular protection and tolerance, particularly with poor tolerance on beta blockers, as let's say the excessive heart rate reduction or the reduction in the increase in the insulin resistance. Is there any difference between, let's say, the different generation of beta blockers regarding the outcome, particularly with third generation beta blockers? We have to mention and to make clear that there is no hypertension outcome trial by using the third generation beta blockers. While we have many studies, hypertension studies with the second generation, particularly with, let's say, bisoprolol and atenolol. And in addition to that, data from the real-world clinical practice show, this is registered from USA, included a reasonable number of patients receiving third-generation beta blockers compared to atenolol, that there is no any difference, let's say, better outcome in patients using third-generation beta blockers compared to the second-generation beta blockers. In these lines, we see here a study using monotherapy, nebivolol, a third-generation beta blocker, compared to a second-generation metoprolol or atenolol in uncomplicated hypertensive patients, and we see here that there is no any difference in the outcome between these two drugs. And coming, let's say, to this specific action on beta blocker of a new third-generation beta blocker or arterial stiffness angioimidation index, we see here that the angioimidation index is significantly affected by carvedilol, nebivolol, and metoprolol, even when we take into account the difference in the heart rate reduction. Last but not least, a significant, let's say, effect associated with beta blocker is erectile dysfunction, and this is here is the famous statement by Tolstoy, recognized the importance of this clinical problem. And European Society of Hypertension have published a couple of years ago a consensus statement updated the role of beta blocker on the erectile dysfunction, and in this paper it is also recognized that beta blockers is not an homogeneous class, and vasodilators in beta blockers, particularly carvedilol and nebivolol, appear not to share some of the negative properties described of the other components, and we have some data, particularly with regarding nebivolol, that may affect favorably the vasculature status and not impair the erectile function. We know that nebivolol, apart from these actions through the beta-adrenergic antagonism, also affects favorably the nitric oxide production, reducing the oxidative stress, increasing nitric oxide bioavailability that leads to the favorable effect not only at the level of heart, but also at the level of vessels, promoting vasodilation and improving endothelial function, resulting in the clinical, let's say, improvement or at least not a deterioration of erectile dysfunction. This is a study confirming this by Michael Dumas, showing that nebivolol has a favorable effect on erectile dysfunction. Having said that, let me move into the last part of my presentation to present what is the current algorithm from European Society of Hypertension for treating hypertension and what should be the role of beta blocker. We are all familiar with this general concept that European Society of Hypertension recommend to start with a dual combination for the most patients. Of course, guidelines give space for monotherapy in specific selected patients, those at low risk with blood pressure below 150, or those at high normal blood pressure at high cardiovascular risk, or for frail and very elderly patients. For all the rest patients, dual combination is recommended with ACE inhibitors, CCBs, or ACE inhibitors with diuretic. But what is important, that the guidelines recommend that beta blockers can be used as monotherapy or at any step of combination therapy. So for European Society of Hypertension, beta blockers are continue to be first-line choices. And what is more important, and I like very much these steps that included in the guidelines that led by Professor Kreutz and Professor Mancia, representing here selected indications where a beta blocker should be first priority, like chronic coronary syndromes and ischemic therapy. All the guidelines for chronic coronary syndromes include beta blockers for treating these patients. Beta blockers post-myocardial infarction, angina, known incomplete revascularization, heart failure, and of course in the setting of acute coronary syndromes. Heart failure with reduced or preserved ejection fraction, particularly in the last case if coronary artery disease is present. Atrial fibrillation prevention, also for rhythm control and for heart rate control. When we have hypertensive patients, hypertensive women with childbearing potential or planning pregnancy, as well as for the treatment of hypertension disorders during pregnancy. We have also a long list of selected conditions in which therapy with beta blocker could be favorable. For example, if we have a hypertension, uncomplicated hypertensive patient with elevated resting heart rate over 80. In case of emergency urgency hypertension, perioperative hypertension, and major non-cardiac surgery. And the list is continued for in a number of other conditions: postural orthostatic tachycardia syndrome, the POTS syndrome, orthostatic hypertension, sleep apnea syndrome is very, very common among uncontrolled hypertension, particularly among patients with resistant hypertension, whereas beta blockers should be used. Peripheral arterial disease with claudication, glaucoma, migraine headache, essential tremor, and psychiatric disorders. So we see that a number of comorbidities associated with hypertension have a clear indication for beta blocker use, and this is the findings from a Greek snapshot we presented a couple of years ago among patients being hospitalized in cardiological clinics. We see here that hypertension is prevalent in more than 70% 70% of patients being hospitalized for cardiac reasons, and diabetes mellitus, atrial fibrillation, CKD, and heart failure are very, very common comorbidities associated with hypertension, where beta blocker has a clear role. With that, I would like to present the conclusion of my talk, saying that beta blockers provide an overall cardiovascular protection similar to other antihypertensive drug classes. Beta blockers are less stroke protective compared to other drug classes for the same blood pressure reduction. Based on observational evidence, third-generation beta blocker seems to provide at least a similar cardiovascular protection compared to other generation beta blockers. However, third-generation beta blockers are associated with less side effects than other generation beta blockers. During lifetime, many hypertensive patients will receive a beta blocker either alone or in the context of a more complex antihypertensive drug regimen. Beta blockers are an appropriate treatment for hypertensive patients who have concomitant ischemic heart disease, heart failure, obstructive cardiomyopathy, aortic dissection, or certain cardiac arrhythmias. Beta blockers may be used in hypertension patients having a prekinetic circulation, migraine headache, essential tremor. Beta blockers can be used in combination with other antihypertensive drugs to achieve maximal blood pressure reduction. With that, I would like to thank you all for attending my talk and looking forward for your comments and your questions. Thank you.
Thank you to Professor Tsioussis for this wonderful presentation. Unfortunately, we have just a few minutes for the discussion since the time schedule is quite sharp. But I have a couple of questions, one for Reinhold and another one for Kostas. Reinhold, just a brief comment on two specific issues. The first one, why, according to your opinion, the development of new drug is only in patients with resistant hypertension and or uncontrolled hypertension? And a second comment about zilebesiran. It's a very promising drug, but what's your opinion on a very long-lasting drug in hypertension, considering potential hypotension episodes?
Two important questions. The first one, I mean, there's no rationale actually why the drugs are being, from the mode of action point of view. It's more strategic point of view, I guess, for the companies if they go to difficult to treat hypertensive patients or with comorbidities, because we have no outcome trial yet. And if they show that they are effective, and even, they, with the ASIS, they go into the outcome trials, then that would be an evidence-based treatment approach that can be used. I give you one example. For instance, this non-steroidal receptor antagonist, esaxerone, has been approved in Japan, not only for resistant hypertension, but also for essential or primary hypertension. It works there very well as well. So there's more strategic point of view, but not a mode of action point of view. And the second question is a very important one, obviously. If you have a long-acting drug and you have patients with, blood pressure is not cholesterol, you have hypotension, you have shock, you have bleeding, and then we may need the angiotensin II levels to maintain blood pressure, and it can be life-saving. There's also a problem in potential in pregnancy. So that's a potential risk. Nevertheless, there is already at the experimental state, at least a kind of approach that's called Reversi, where you can, based on the technology used by suppression of the expression, you can stop that by injecting a reversal agent that has been tested by the group of Jan Danza in Rotterdam, for instance. He's developing this, and then we are waiting for potentially move to the clinic or hypertensive patients or humans first. But it works, you can stop, and that would be kind of a reversal agents, like patients that have bleeding during oral anticoagulants, for instance, that we have a reversal agent. And that would be a potential saving issue, which would be very important for this type of approach.
Okay. Thank you very much. And Kostas, also for you to comments. The first one, why, according to your expertise, ESH guidelines state that beta blockers are first-line drugs, but the European Society of Hypertension they just limit as a second line. First question. The second question, considering that we push a lot combination therapy, what are your preferred combination with beta blockers?
Yeah, thank you, Stefano, for these important and clinical questions. First of all, traditionally, European Society of Hypertension always has placed beta blockers as first-line therapy. Of course, we have changed our concept in the last edition, 2018, introducing combination therapy, fixed dose combination therapy for the majority of patients in order to improve the adherence, and by improving the adherence to improve the blood pressure control and the outcome. But always it was stated that beta blockers should be part of the therapy at any step of the therapeutic algorithm. Coming to the European Society of Cardiology and to NICE guidelines that unfortunately this year we have separated guidelines. Beta blockers, let's say, they don't recommend beta blockers as first-line therapy. But practically speaking, when all agree that beta blockers should be prescribed in a reasonable number of comorbidities associated with hypertension, I think that in the end of the day, both guidelines agree that beta blockers should be can be appropriate treatment for every hypertensive patient with very few exceptions. Of course, there are different interpretations regarding the protective effect of beta blockers in a number of endpoints, particularly for stroke. But I think we have clear evidence that compared to placebo, beta blockers also reduce effectively the blood pressure, and by reducing the blood pressure, reduce the risk for stroke. So I would say that nowadays this is also the common practice among physicians treating hypertension, that beta blockers represent an important tool, an important therapeutic option with when we manage cardiovascular disease with or without hypertension. Coming to your second question, if we have to combine beta blockers, of course, if a patient has a beta, apart from hypertension, coronary artery disease or heart failure, I would be in favor to combine beta blocker with a RAS blocker, ACE inhibitor, or angiotensin 1 receptor antagonist. But I think that, of course, now there are available drugs combine beta blocker with CCBs, if there is such a possibility. So I think that also with diuretics. So we can use any type of combination that we would like for treating hypertension and a number of comorbidities, depending on the specific profile of the patient. And according to the needs, we have to adjust the appropriate combination for treating this patient.
Thank you very much, Kostas. And now it's time for the closing remarks. First of all, let me to thank the distinguished colleagues, great scientists, but also great person. And just to remind you that for the certificates, you have to complete the post-webinar survey at the link provided in the chat. You have in the chat, so you can connect, complete the post-webinar survey, and then you can download the certificate. Next slide, please. Okay. I also remind you that starting from 27th of June, you have on-demand webinar, so you can connect to the media e-learning platform, and you can just listen the webinar, and you can have the credits that are available until 20 December of this year. And finally, I just remind you next appointments with the media learning program. We have 2 podcasts, one with Professor Amir Lerman from the cardiovascular division of Mayo Clinic about coronary artery disease treatment, another podcast with Professor Rosa Maria Bruno from the University of Paris about resistant hypertension, and finally a video interview with the Professor Atul Patak from the Department of Cardiovascular Medicine of the Monaco Hospital. Please follow us in media social. You can have all the social you prefer, and thank you very much for your attention, attendance, and your participation. Thank you, and welcome to the next media event.
Thank you.
Thank you.